Choosing the best chemotherapy for you after pancreatic cancer surgery. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon. And if you or someone you care about has just undergone surgery for pancreatic cancer, and you're trying to make sense of what comes next, modified FOLFIRINOX, Gemcitabine plus CAPCEITABINE, and Gemcitabine plus nab-Paclitaxel, you're in the right place. These three options present distinct chemotherapy regimens. I know when you hear these complex drug names and you're trying to understand survival statistics, it can feel overwhelming. Adjuvant chemotherapy means chemotherapy given after complete surgical removal of pancreatic cancer. The goal isn't to shrink a tumor that's still there. It's to eliminate microscopic cancer cells that might be circulating in your body that we can't see on scans. This is absolutely critical because even after what appears to be successful surgery, pancreatic cancer has often already begun spreading at a microscopic level. Research demonstrates that 6 months of adjuvant chemotherapy significantly improves survival compared to surgery alone, where no chemotherapy is given. In the landmark CONKO-001 trial, 5-year survival improved from 10% with surgery alone to 21% with gemcitabine. That's more than double. This is why adjuvant therapy is now considered standard of care for all patients with resected pancreatic ductal adenocarcinoma, including even those with the earliest stage disease. Modified FOLFIRINOX, that stands for fluorouracil leucovorin, irinotecan, and oxaliplatin, is a 4-drug combination that has revolutionized outcomes for patients who can tolerate it. The PRODIGE-24 trial, which followed 493 patients for over 5 years, compared modified FOLFIRINOX to gemcitabine alone. At median follow-up of 70 months, modified FOLFIRINOX achieved a 5-year overall survival of 43% compared to 31% with gemcitabine alone. This is a significant development. This trial only included patients between 21 and 84 days after surgery who had a performance status. The concept of performance status and how it is measured is important to understand. The score of 0 or 1 means people who were fully active or only restricted from physically strenuous activity, with adequate kidney and blood counts and no heart problems. These aren't arbitrary restrictions, they're critical for safety. You can pause here and learn about the ECOG performance chart from the image. Modified FOLFIRINOX causes more side effects. Grade 3 to 4 adverse events, meaning severe enough to significantly impact daily function, occurred more frequently. Diarrhea affected 19% versus 4%, with gemcitabine alone. Sensory neuropathy, that tingling or numbness in hands and feet, affected 9% versus essentially none. Fatigue occurred in 11 versus 5%, and vomiting in 5 versus 1%. If you're supporting someone through this treatment, understanding these side effects matters enormously. Severe diarrhea means ensuring they have rapid access to bathrooms, staying extremely well hydrated, and having anti-diarrheal medications readily available. Neuropathy can make simple tasks like buttoning shirts or walking difficult and may be permanent. Your loved one needs you to understand this isn't them being weak. These are real medication effects requiring patience and practical support. While there are no trials directly comparing FOLFIRINOX with gemcitabine plus CAPCEITABINE in the adjuvant setting, meaning right after surgery, gemcitabine plus CAPCEITABINE represents a reasonable alternative for less fit patients. The combination has established efficacy and a more manageable side effect profile than FOLFIRINOX. Current clinical practice guidelines suggest this regimen for patients with a borderline performance status or comorbidity profile that precludes the more intensive 4-drug combination. Think of this as the option when FOLFIRINOX would be too much, but you're still healthy enough to benefit from combination therapy. If you're worried about someone you love who has other health conditions, maybe diabetes, heart disease, or kidney problems, this middle ground option might allow them to receive effective treatment without overwhelming their system. Remember, the most effective chemotherapy, FOLFIRINOX, is best deployed in fitter patients. See the ECOG scale for comparison. The third major option combines gemcitabine with nab-Paclitaxel, which is nanoparticle, albumin-bound paclitaxel. This regimen became widely used in metastatic pancreatic cancer and generated interest for adjuvant therapy. The international APACT trial randomly assigned 866 patients to 6 months of gemcitabine alone or gemcitabine plus nab-Paclitaxel. The other alternative to FOLFIRINOX is gemcitabine plus nab-Paclitaxel. At median follow-up of 38 months, the combination didn't significantly improve disease-free survival by independent review, median 19.4 versus 18.8 months. However, in extended follow-up, overall survival did improve, median 42 versus 38 months, with 5-year overall survival of 38 versus 31%. Based on current evidence for patients who cannot tolerate FOLFIRINOX, both gemcitabine plus CAPCEITABINE and gemcitabine plus nab-Paclitaxel are considered reasonable alternatives. This is determined by something called ECOG performance status, a scale from 0 to 4, as mentioned previously. This is an important concept in chemotherapy choice. ECOG 0 means you're fully active. able to carry on all pre-disease activities without restriction. ECOG1 means you're restricted in physically strenuous activity but ambulatory and able to carry out light work. These functional assessments help determine which treatment your body can handle. If you have an excellent performance status, ECOG0, modified FOLFIRINOX is preferred. If you have a good performance status, ECOG0 to 1, FOLFIRINOX is still preferred over gemcitabine-based combinations. For patients with a borderline performance status or significant other medical conditions, gemcitabine-based regimens are more appropriate. Can you walk around the block without stopping? Can you climb a flight of stairs? Can you prepare your own meals? Adjuvant treatment should ideally start within 8 weeks of surgery. Before beginning, you'll undergo restaging with CT scans and a blood test for CA19-9, a tumor marker. The standard duration is 6 months of treatment, regardless of which regimen you choose. If you're someone who had chemotherapy before surgery, what we call neoadjuvant therapy, current recommendations suggest additional chemotherapy after surgery to complete a total of 6 months of systemic treatment. Document your current functional status honestly. Write down what activities you can do without difficulty, which cause some limitation, and which you cannot do. Track how far you can walk, whether you can climb stairs, if you're experiencing any symptoms like pain, nausea, or fatigue. This information is gold for your oncologist when selecting your regimen. If you're likely to receive FOLFIRINOX arranged for help with transportation, you'll need someone to drive you to treatments. Stock your home with anti-diarrheal medications, anti-nausea medications, and easy-to-digest foods. Set up a simple bathroom schedule and hydration tracking system. Optimize your nutrition before treatment starts. This isn't about special diets or supplements. It's about maintaining adequate calorie and protein intake. If you've lost weight after surgery or have poor appetite, meet with a dietitian now. Patients who enter chemotherapy with better nutritional status tolerate it better. Come prepared with specific questions. Based on my performance status and medical history, which regimen do you recommend and why? What is my realistic 5-year survival expectation with this regimen based on my specific pathology, my tumor stage grade, and margin status? If I develop severe side effects, what dose modifications are possible while maintaining effectiveness? Ask about your specific pathology results. Were my surgical margins completely clear, meaning no microscopic cancer cells left behind? What was my lymph node status? Had the cancer spread to the lymph nodes? If so, how many lymph nodes had cancer cells? What tumor grade did pathology show? These factors significantly impact prognosis and might influence treatment intensity. These 2 images clarify the concept about margin status and lymph nodes. Discuss genetic testing if you haven't had it. Ask your doctor, should I undergo germline and somatic tumor testing for BRCA1/2 PALB2 or other mutations? Patients with certain genetic variants may particularly benefit from platinum-containing regimens like FOLFIRINOX, according to published research. Know the warning signs that require urgent evaluation. Temperature of 100.4 degrees Fahrenheit or 38 degrees Celsius or higher during chemotherapy. This could indicate a life-threatening infection when your white blood cell count is low. Severe diarrhea, more than 6 bowel movements per day, or inability to keep down fluids. Uncontrolled nausea and vomiting, despite taking prescribed medications. Severe abdominal pain. Any bleeding, worsening numbness or tingling that affects your ability to walk or use your hands. If you're caring for someone receiving treatment, these symptoms require immediate action. Call the oncology team or go to the emergency room. Don't wait until morning or until the next scheduled appointment. Modified FOLFIRINOX offers the best survival outcomes for fit patients with 5-year survival of 43%, but requires excellent functional status and comes with more side effects. Gemcitabine-based combinations provide effective alternatives for less fit patients. Your next step: have an honest conversation with your oncologist about your performance status and which regimen matches your individual situation. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.